happy Tuesday. I just had pelvic floor PT, and then came home and made breakfast. I am about to log into my pelvic congestion appointment, follow-up, whatever you want to call it. It's virtual, thank God. I think I'm gonna record this for you guys because I recorded the first one, so might as well just keep the transparency, and that'll be less that I have to explain afterward, which will be nice. Immediately after that appointment, I have my internship meeting, and then immediately after my internship meeting, I'll be leaving to go do my small fiber neuropathy testing. I'll see how much I can record of the small fiber testing. I can't make any promises. Don't know what it's gonna look like. From what I understood, it's like a skin punch biopsy versus my EMG was kind of like electrodes per se on my limbs and hands and things. So I don't know exactly what this is gonna look like, but yeah, I'll do my best. I'll keep you guys updated throughout the day, but I just wanted to check in and say that.
I'm one of the nurse practitioners. Still have appointments with you today to go over the imaging that you have done.
Okay.
With Dr. McDuffie. Unfortunately, I cannot log on to, I don't know what the program's doing, where I could show you the actual images from what you just had done, but I can at least pull up your CT scan and tell, to kind of correlate with what she was reading.
Okay.
How's everything going up since we talked to you last, though? About the same, or?
A little bit worse. I've lost more weight. I have J tube placement and gastric bypass next week, actually. So yeah, just trying to keep steady eating as much as possible. My energy's been up and down. Actually, it's been a little bit better, but yeah.
I'm sorry, that's lots to go with.
Thanks.
How much have you lost so far?
In total, 25 pounds. 25. Yeah, I was 111. I'm 86 now. So whatever that is.
So what? So you had the MRV done on the 5th of March. If I'm not wrong. What Dr. McDermott read. So her exact words are: the left renal vein appears to have severe compression with an enlargement of a draining lumbar vein. So a lot of times when we mention the lumbar veins, they go up the back of the spine. We consider those kind of a collateral circulation for neck.
Okay.
Are you getting a lot of flank pain?
Yep.
So more than likely you have the symptomatic nutcracker syndrome, and that's why your lumbar veins are draining from there. You'll also have an enlargement and reflux in the left gonadal vein, which is an ovarian vein that comes off of that left vein.
Okay.
On the right side, it feeds into the IVC, so it's a little bit different. On that left side, it comes pretty much straight down to the iliacs from that left vein.
Okay.
There's brisk flow across the uterus and branches of the right gonadal vein, which is kind of like shunting almost, if you will. So like on that left side where the compressions are, it's shunting over to the right to be able to go back up to the heart.
Okay.
So another kind of indicator of having these compressions. And then you have a long segment, severe appearing compression of the left iliac vein. So that may Thurner's anatomy, with asymmetric enlargement of the left ascending lumbar vein. So again, your lumbar veins are really taking control, trying to get that blood back up to the heart. You're having a lot of back pain
all the time.
Yeah. So that, and this is all of the symptoms kind of correlating with what we're seeing on that MRV.
Okay.
Also, prominent pains in the pelvic floor, which means, if you say during like either intercourse or tampon insertion, or even just sitting during your period, if you get that like really tenderness or fullness or throbbing along that either labia or inside the vagina, that's because you have a lot of those varicose veins kind of hanging out that pelvic floor.
Okay.
And then she says, based on all of this, it's reasonable to consider the venogram, the left iliac venogram, with a possible stent placement.
Okay.
And then at that time, so the reason we always start with this is, has any of our providers talked to you about how treatment for nutcracker goes?
A little bit.
Okay. So for nutcracker treatment, if you're having symptomatic, issues like the flank pain that keeps going on, blood in the urine is another big indicator if you have that. What we do is called a renal auto transplant, which is basically just moving your kidney down to a different spot to get rid of that, which is an extreme, like a very large surgery. So a lot of times we like to start with the iliac vein treatment. Okay. Because sometimes we see in over half of the people that they see improvement in the nutcracker symptoms after having the iliac vein treated for their compression. Okay. So kind of like a stepwise process on, least invasive to most invasive, so to speak. Totally. So I like to start with that left iliac vein possible stenting. At that time, she'll do what's called pressure gradients of the checking the nutcracker anatomy. So it's not like leaving it completely alone. We want to see how significant it is, what the amount of compression is based on the before the stenosis and after the pneumonia. So that's kind of like a gradient measurement. Okay. So she'll do all of that at the same time. If stent is deemed necessary at that point, that's when she would put the stent in. Okay. For nutcracker treatment afterwards, we do have some options to kind of determine if that's where your pain is coming from. We like to give you a couple months just to kind of decompress from having the iliac vein stented. If you're still having a lot of that flank pain, you're having blood in the urine, any of those issues, we do what's called a renal highlight block, which is a nerve block of the kidney area to see if that is what's actually the cause of your pain. Okay. If your pain goes away, that says it's nutcracker. If it doesn't go away, we're probably dealing with something. Okay. And then I can try, I'm really sorry, but I don't know what's going on with my health imaging, but that's what she saw. Okay. Let me pull up at least the CT, we can see the CT on there, I'm sure. And I'm pulling up the one it's going to be in February was the CT, okay? Okay. Can you see that okay? Yeah. Okay. We're going to move down. Again, this is going to be the left side, this is going to be the right side. Right side, left side. And then right here is going to be the left kidney, okay? Okay. So where we're looking for, this is going to be the left renal vein coming across. Oh, this is not a very good picture, huh? Basically, right here, this is the superior mesenteric artery, and then this right one right here is the aorta. So that's where the left renal veins get entrenched. You can basically see almost complete efface, like it's kind of disappearing behind that aorta right there. So that's that degree of, or the significant degree of nutcracker. And it is better on the MRV to kind of visualize it, but I hope that kind of gives you an idea of where it should be kind of crossing here with a nice open space. It's really just comped off completely from these two arteries, smushing it in between. Okay. And then moving down, you don't see the timing very well from right here, but right about here, you can't see the vein at all. But this is where we see that left iliac vein compression. I'm sorry. Do you want me to see if I have one of my coworkers logged in working so we can see the MRV a little better? Let me see if I can get logged on to someone else. I might just have to call you in about 20 minutes, okay? Okay. Okay, so far, that was a lot, first of all, very quickly. But, I don't know. Honestly, that was just a lot. I'm not even going to try to, make it, over positive or just, brush it off. That was a lot. Yeah, it'll probably be better if I just rope you guys in after, because I'm also thinking of treatment, obviously, in the scope of my other two surgeries and what that timeline looks like. And so I'll ask those questions, obviously, but yeah, it's just a super medical year and I'm already over it. Is that okay? Yes. All right, we're gonna go to the phone one here. So where we see iliac vein compression, it's gonna be right under here going across. I don't know if you can see that little shadow. But this part right here is your right internal iliac artery, left external iliac vein kind of going across and getting smushed. And then if we go up to about right there, See, this is going to be the left renal vein trying to get, and it's really like where you see it kind of seems dilated too.
Mm-hmm.
That's where this smush is happening. It's kind of like a hose. So there's all that pressure on the back feeding to where that left iliac vein is going. And you can also see this little spot right down here?
Yeah.
That's one of the lumbar veins that is trying to compensate. So you have that one on the side of the mouth.
Okay.
So I think overall, a lot of the symptoms that you're having, while they might have to be done in a segment, are you okay if I stop presenting and talk to you again? Yeah. Okay. Just making sure. And it might be a stepwise process. I think it's the biggest thing to be aware of for what you have going on. And I think you're more than used to that, just hear from what kind of goes on already. Like I said, the main thing is going to be trying to fix the left iliac vein compression. So that would be that stent placement. Did you have any questions about that procedure? Or did they go over it kind of with you? I know you did a video.
I don't think so. Not like fully.
Okay. So what the procedure entails, it is done outpatient. It's not like where you need like a breathing machine or anything to they don't put a tube down your throat.
Okay.
It is done, Dr. McDermott in the outpatient suite downstairs.
Okay.
It's basically a needle site with a camera on a long one. And that's called intravascular ultrasound. And she can use that to kind of get a bunch of measurements of the sizes of the veins, the degrees of compression. So one, it's diagnostic because what we see from the outside may not always match what we see on it. Based off of that, she kind of takes those measurements, determines if there's a need for a stent, and then that's when the stent is placed.
Okay.
It's no more than usually 2 to 3 hours. The biggest thing is, you can expect a degree of back pain. It is a stent made out of metal. Did you happen to indicate that you wanted metal testing? No. Metal. Okay. The access site is in the left leg, so it's called the great saphenous vein. Occasionally, she will have to do a second access site in the internal jugular. Okay. It's just, it's kind of hard to go up and around to measure things if the anatomy doesn't allow it very easily. Okay. It's done with an anesthesia provider in the office, so it's either a CRNA or an anesthesiologist. I know we went through the anesthesia questionnaire with you last time. Any issues with anesthesia in the past?
No.
Okay. Yeah, and it's conscious sedation, so you get some propofol, you get some nausea medication, possibly some steroids. And when we wake up, we try to get you back on at least being able to tolerate the pain medication, tolerate the pain before you go. Okay. Recovery, there is some back pain to be expected because where that stent is placed, it is very close to the spine. Now that back pain can range from being very mild to some of the worst you've ever felt. It's just really, really patient dependent. We have found that a lot of times the younger women don't tend to have as much back pain or it doesn't last as long, but there is some degree. Mm-hmm. I would like to just warn people because I think a lot of times if you think there's no incision, it's not bad, but it can
not
be.
True. Yeah.
We are there for all the pain medications or needs you may have. What have you tolerated in the past?
As far as pain meds?
Mm-hmm. Yeah.
Tylenol 3. I don't do well with tramadol. I know that for sure. But Toradol works well too.
Toradol?
Mm-hmm.
Okay, yeah. And Toradol we can give, usually she'll do IV during the procedure. Okay. What we normally give for pain medication in a stepwise approach would be 1 tramadol, so we'll X that up completely. Okay. And then we would either do oxycodone or Dilaudid. Okay. And then, have you ever tried muscle relaxers?
Mm-hmm. Yeah.
Okay. Any of those work okay?
Yeah, cyclobenzaprine works well.
Perfect. So we do offer that too, just a lot of times because your back can kind of, not so much in the first couple weeks, but kind of like 3 weeks to 1 month mark, you can notice some back spasming just because you're kind of guarding that area from having it. Mm-hmm. And we also offer, if you need it, we can give you some like gabapentin, that kind of thing as well. So we try to make sure your pain is at least as tolerable as possible. 1 month is about when people kind of start turning the corner and you start seeing improvement. Okay. At that time too, like I said, she would check the renal vein. What she'll be doing is the pressure gradients, determining how severe it is from inside. And then of course we can always talk about that renal hilar block as the next stepwise approach for treating the nutcracker if you're still having a lot of pain. Okay. Follow-up, we see you after 1 week just to make sure your access sites are okay, that you're recovering okay. at 3 weeks, we do an ultrasound.
Okay.
The ultrasound just to make sure that skin's nice and open. And then we do put you on blood thinners for those 3 weeks too.
Okay.
It's usually Eliquis, 5 milligrams twice a day. Big thing with that is if you're having periods, it will make that a little bit scarier or worse just because it is a bleeding medication. After that, we just put you on aspirin.
Okay.
Aspirin will be for 2 months, and that's just try to kind of, it's not a super anticoagulant, it's just to make sure things stay nice and open while you're in the inflammatory stage.
I'm allergic to aspirin. Is there an alternative that we can use?
I mean, if you're allergic, what happens when you take aspirin? You have the
hives and nausea.
Yeah. Honestly, we'd probably just either keep you on the Eliquis or not have to take anything.
Okay.
There's aspirin alternatives, but because there's not, I mean, if we're just going to keep you on anticoagulant, we'd probably just keep you on either Eliquis or Pradaxa.
Okay.
Sometimes Eliquis can act funky with our younger women, like they get just kind of goofy side effects, like either dizziness, vertigo, that sort of thing.
Okay.
If that happens, we have other options. We can just go to Pradaxa, which is basically the same medication.
Okay.
And I don't know what the future holds for you or anything, but I always like to mention before young, if pregnancy is in the line down in the future at some point, there is no issues with having a stint and being pregnant. The only thing that we recommend you do is let us know.
Okay.
And then at 20 weeks, we recommend you go on a Lovenox shot, which is just another anticoagulation. Not just because baby can kind of push on the skin.
Totally. Okay.
If for some reason you do get COVID, we have noticed that you have a higher risk for blood clots. So we do put you back on a blood thinner, Eliquis, for about 3 weeks when you have an infection.
Okay.
We recommend not getting the vaccine for a year, but if you do, we just put you back on Eliquis for.
Okay.
All right. Any questions for me? I know that's a lot again.
Yeah. Yeah, as far as timeline, so I'm doing the GI surgery next week, and then I have endo excision in April. How soon or like how long should I wait after the endo surgery to start something like this?
So the way we work, especially with having Medicaid, they will not let us do procedures downstairs. So they have to be done at LAH, at Littleton Hospital.
Okay.
The wait list for that, because Dr. McDermott was kind of involved in your case, reading your imaging, she is able to see you a little sooner than Dr. Spencer would be. It's still a pretty long wait list for hospital procedures. We're talking like into the fall.
Okay.
So there's really no wait for that. But once we get you in the books, Dr. McDermott's probably more like October, November.
Okay.
And then if you would prefer to just whichever surgeon's available sooner, we do have another one coming in to join the practice as well. Okay. It's kind of cute. Yeah, and then as far as that goes, you'll get a call from kind of their anesthesia, from the nurses there when your procedure is about to happen. You will follow up one of us about 2 weeks before your procedure just to make sure nothing's changed. And then we can kind of go over all the questions if it's urgent.
Okay. See. Okay.
Any questions? I know it's a lot.
That's it. I know.
We got tons of time. But yeah, and then like I said, I think the biggest thing we both want to stress is that you do have that severe degree of compression in the iliac vein and in the left vein.
Okay. So
the stepwise approach, the other thing we consider too, if you want, your flank pain, is it pretty, what's your biggest pain you're dealing with right now?
Out of everything, probably the just pelvic floor pain, all the way, the band all the way around. And then I get a shooting bone pain. It's almost like shin splints, but higher up. The left is worse, but it does happen in the right sometimes.
Okay. Yeah, the reason I ask is when we think about, we want to treat symptoms first, especially when you have both conditions. If it was more so that flank pain, blood in the urine, that sort of thing, we could move with having that renal hylar block. But I think it's best to focus on the pelvic pain first. And see if that will help improve.
Yeah.
If for some reason it gets worse and you want to try to see if it helps with your pain at all, just let us know. We have a Dr. Brown at Skyridge here. He does what's called the renal hylar blocks to see if that helps with your pain at all. Okay. But at the same time, I would rather stent and see if that improves rather than the full
Yeah.
your kidney surgery.
Totally. Yeah. Yeah. That sounds like the right idea. Yeah.
Yeah.
Okay.
And then, all right, and then of course, if you think of any questions, just give us a ring. We can always do like a short follow-up or just give you a call back.
Okay.
All right, well, I hope everything goes well next week.
Thank you.
Just start, feeling better, getting some energy back.
Yeah.
That's probably more than
Thank you. I have a good like 25 minutes before I have to log into my next meeting, but I want to like rub my whole face so bad, and I'm wearing a full face of makeup. I just feel like I kind of can't breathe, to be honest. I think the biggest thing that I'm thinking about, it kind of feels like the endo diagnosis where I'm just thinking back to the very moment I started puberty and all of these symptoms that I've been feeling for, how old am I? 12 years. I got my period when I was 9, and the very first time and every time after that was excruciatingly painful, debilitating, like hard to go to school, hard to be anywhere, hard to sit up, hard to like everything. So I'm thinking about these diagnoses and what they're seeing in the imaging, and I'm just trying to track back to like how long has this been going on, because I thought, I don't know, when I got diagnosed with SMA, that felt like something that was new alongside the gastroparesis, but even thinking about the symptoms of the gastroparesis felt like this had to have been going on longer than August, when I finally just got so tired of my GI symptoms because they kept getting worse. Same thing, I've been dealing with severe GI symptoms since I was anywhere between 9 and 12 that I remember. And it's always been brushed off as you're young, you're going through puberty, you're any lazy explanation ever. As I got older, and a part of searching for diagnoses for like my full body pain and fatigue and all the things, part of that was leaving pediatric doctors and going to see adult doctors, including adult GI, and it was always just ruled as reflux. You just have really bad reflux. And every medication that I tried did nothing for me. Even when I got my upper endoscopy, he diagnosed me with Barrett's esophagus, which is your esophagus is exposed to so much stomach acid that, I hope I'm explaining this right. If not, I'm just gonna cut it out. But your esophagus is exposed to so much of your stomach acid. My esophagus was like precancerous. And he said in my actual stomach, he just found a bunch of inflammation, and so I had to go on the like GERD diet, which is like no chocolate, no caffeine. I had to get rid of hot sauce, things like that. Obviously low acid, no tomatoes, no lemon, citrus. But that was all he found. And I'm just thinking back to, again, all of these symptoms and all of these lazy diagnoses, and now I'm looking at this notepad full of stuff that's not even a 12th of my health history and current diagnoses. And it's just so frustrating to not 100% be able to pinpoint, like, yeah, I've had May Thurner since I was 9, because I don't know. But at what point, I don't know. I think I'm also just frustrated because, like, I do want someone to blame. I've been sitting in doctor's offices for years begging someone to figure out what's wrong with me, and it took so long that I feel like the severity of all of the stuff that I'm going through now has to be some consequence of being dismissed for so many years, and that's what's frustrating. So, but I don't know, like, I can't prove that. Yeah, I don't know what I was expecting out of this appointment, but, and I think, honestly, I do think it's a good thing that I wasn't, like, particularly anticipating anything. But yeah, I'm just really frustrated and exhausted. And considering the doctor's schedule, so if it wasn't clear with the audio, they're scheduling out into the fall. The one in the fall that they would schedule me for is just the stent placement for the May Thurners, and then I recover, we track my symptoms and progress and all the things, and then we would do the kidney stuff. I don't know why, but I think just the severity of everything is, like, really hitting me now. Because I'm just thinking about work and school and what all of this means for my schedule and my goals and my desires. And I was thinking about that last night, but it was really just in the context of these next 2 surgeries, GI reconstruction and then endo removal. And yeah, like, I knew that the stent surgery was on my radar, and, you know, possibly the auto transplant, but I think because it was still slightly more hypothetical than today, it felt different. It didn't feel as heavy. It didn't feel really like a burden. I think I've really just been trying to, like, be okay with everything and just get through it, because, like, I don't have a choice, you know. But I think today just feels different. Future me here is sitting editing the vlog, and now that I've had even more time to process, I think the thing that's really bothering me the most that I'm trying to articulate is the fear of, like, becoming dependent. For such a long period of time, it's one thing to take a week off of work for a lupus flare. It's another thing to take a month off, right, for a couple surgeries, and there's government supports and everything that I'm in the process of getting approved for, but just the sole idea of I'm out here by myself, which is what I wanted and which is what I love. I don't regret moving out here, you know, considering that changes the dynamic of my support system. But I'm responsible for my rent and my bills. I have family that has been generous enough to send what they can when they can. I have friends here that, you know, will buy like groceries when I need them, or, you know, take me places, like will help make sure that I'm taken care of. But ultimately, like, that's not anyone's responsibility. And so I think my fear is, as my needs get more expansive, what does that look like for me to still be able to support myself, like, in a big way? You know, so not making money, having regular hours at my job, even, you know, working from home, that's scary. Even with the opportunity to go back to school online, will it be another situation of, look, I'm trying to do my assignments and do my best work, and at the end of the day, I'm either not retaining information or I'm just doing assignments for completion and not, I mean, that kind of goes into the not retaining information, right? So if I do graduate, I don't have the knowledge that I would want to have to, like, start my career. So these are all of the things that I'm thinking about and I'm frustrated about. It makes me really nervous to be, like, down for so long. I know that it's what needs to be done, and I'm more than willing to go through this process. Like, that's not what I'm resisting. Again, my fear is not being on the table. It's the aftermath. It's what recovery feels like. It's immune system risks. It's being able to still support myself and not get evicted, being able to continue working on my degree. I just think I'm afraid that I'm gonna feel stuck and helpless. And I would love to be a cliche and be like, God's gonna work it out. Like, I know He is. Like, I don't want to use that as a cop-out for, like, doing my part in preparing and making sure that if there are things that I need to put in place to make sure that I'm good, that I do those things. I go in for surgery in 3 days, and I think, like, I've been getting the Sunday scaries for the last few days because it's just felt so much more real the closer it gets. Anyways, I just wanted to add that little caption because that's really what was going through my head, and I just felt like I could have articulated that a little deeper. So it's just hitting me how severe everything is. I feel like I've just been hearing that word from my doctors lately, and what's frustrating about that is that I feel like it's been severe for years. I feel like the message that I keep getting from the healthcare system is that I'm not worthy of treatment or taking the extra time to do the digging to find out what's wrong until I'm, like, literally on my deathbed. Like, why did it take getting this bad for everyone to pay attention? Like, that's what gets me every time. Like, I've been sounding the alarm for years and everyone turned the other way. And now, like, I'm at a point where I've literally had to stop my life, pause everything that I want to do and accomplish, and even simple things like stay out later than 7 p.m. without physical consequences. The basic things in life that most people don't have to think twice about, but I have to rearrange and dismantle my entire life because of my health, and it's just not fair. Yeah, I don't know, I just can't. Jesus. God, I need you so bad. Really out of it. Well, thank God for waterproof mascara and setting powder. I have to prep for this meeting. I'm exhausted. Thanks for coming along. Yeah, I low-key just want to dissociate for the rest of the day. Like, I think I've had enough. Pray for me. I've been laying here for about an hour or so now. That appointment was just a little bit stressful at the beginning. As we were pulling up, I realized that I was 15 minutes late. I don't know why, but I thought my appointment was at 2:15. It was in my calendar correctly, and I just, with the day I've had, I don't know, I just read it wrong, I guess. And there was traffic and construction going on. There's a light out on the street right by my house, so it just was chaos getting there. They still took me in, which I really appreciated. And then come to find out, the front desk put the appointment in wrong. So they put it in as an EMG, even though on 2 separate occasions when I was on the phone with them, I had them confirm that it was a small fiber test. And why that's important is because my appointment was in the afternoon. Once they take the biopsy, it has to be shipped with FedEx the same day. The lab has to get it while my nerves and my skin tissue is still alive. So they have a very limited window. Luckily, the doctor and the, I guess, nurse, or I don't know what her proper title was, but they were super generous. They called FedEx. They let me know what was going on. They called FedEx to see if they would come back around before 5 p.m. and they agreed. So we were able to, even with all of the mix-ups and me being late, we were still able to do it. We did all 3 of them on my left side because my left side has the most severe symptoms. So we did from my wrist and then my calf and my foot. I don't know what the area looks like yet. I hate holding this. And I can't take these bandages off for the next 24 hours. So I'll show you guys what the wound looks like tomorrow, obviously with the trigger warning, just if you're interested. Yeah, it didn't hurt. I got local lidocaine injections, so I didn't feel anything, which was nice, and I'm still numbed up, so I really don't feel anything. Yeah, I leave for life group in like 30 minutes. I haven't eaten anything yet. I'm just too exhausted. I kind of am really craving a soft-boiled egg or 2, but I put eggs obviously in my French toast this morning, and considering I'm allergic to eggs, there's a limit. So I don't know if I'm gonna go there, but my only other craving right now is a cheeseburger. And I'm allergic to beef, so it's not really a matter of if I'm gonna avoid my allergies or not. It's a matter of which allergy am I going to partake in today. I have like about 5 minutes to decide that, because if I decide on a burger, I need to get up and walk down the street. And I really don't want to do that either, but it's not necessarily that I want to do that any less than walking to my kitchen right now. So I don't know. I'm just kind of like in a crappy mood right now, to be honest. So I just want to survive the rest of the day, but wanted to update you guys on that. Probably end the vlog, because I mean there's other things going on, but probably not anything else that I'll be filming. So here's the official outro. Thanks for watching. Ugh. Ow, ow, ow. Oh my gosh, it stabbed on there. I guess. Well, it's put through, that's nice. Twist it off. Like, what are we doing here? Oh.